I welcome you to our webinar. This webinar was sponsored by the nonprofit organization called Physician Circle for Patients, dedicated for providing and encouraging the high quality care at lower costs. Today, it's my pleasure to introduce you to Enrique. Enrique is the CEO of the innovative pharmacogenetic company, revolutionary company which will really help you to identify why one drug should work for you or not. So, Enrique, tell us about you and as a main speaker, Dr. Bonilla.
Thank you, Doctor. Thank you for that introduction. It's a pleasure to be here and to have the opportunity to present this amazing work by Dr. Ruben Bonilla Guerrero that developed and the team at Innovative GX Laboratories. We together developed a program that helps patients understand which medications work for them. And I wanted to introduce to you the person who will be mainly discussing this, as this is his expertise. He was formerly Mayo Clinic doctor for 18 years and then moved to Quest Diagnostics. He was medical director of medical affairs, and then he was vice president of Admira Health, to then come to Innovative GX to really create this very powerful test that provides help to more patients than it ever did, and it allowed to help more people, basically. So, Doctor, if you want, take over here and let's start the presentation.
Thank you, Enrique. That's great, and we have a great doctor who had done a lot of work on this. So we want to see everything from him. So let me tell you, my promise to you here today: if you stay with us for a whole conversation, which will last you about 45 minutes to 1 hour, you will have chance to ask any question you want to. You just go to chat and put that question there. So just imagine a patient who's suffering major depression. This is the testimonial from a patient, Raj, who's 41-year-old, and ultimately found the right drug using new technology, the PGX. So Dr. Ruben, please tell us why one drug will work for me, but not for my brother.
Thank you very much, Dr. Agarwal. Enrique, thank you very much for the introduction. Thank you, everybody, for being here and spending some time with us learning about what is pharmacogenomic testing and what everything else it can do for you. All right. So why one drug will work for my brother and not for me? This is actually relatively simple, and I'm going to exemplify it using one very important gene called CYP2D6, which is an enzyme that metabolizes a large percentage of medications that we use, whether it converts them from an active compound to a compound that will do what it's supposed to do, or the other way around, an active compound deactivating it so we can excrete it. When a patient is born, of course, two different sets of genes come together, one from mom and one from dad. Once you put them together, combine, define the functional specifications of every single protein that we make. One of these proteins is the CYP2D6 enzyme. And in the general population, it works very well for some people, which is a normal metabolizer, that's your NM at the bottom. Your poor metabolizers, meaning that it works very slow, so it doesn't metabolize correctly or at fast enough rate the medication to make enough medication that will treat you or to get rid of it. Intermediate metabolizers, so it's a little bit decreased activity. It still does what it's supposed to do, but not in a very efficient manner. And then the ultra rapid metabolizers, that means that you get rid of everything really fast or you activate it very fast. And as you can see, this distribution or type of activity of this particular enzyme is not equal for all populations. And that's very important when one puts together an assay that will cover all those different racial and ethnical differences that we have while we all have the same genes, we have different versions of them. And they are reflected on what is called SNPs, single nucleotide polymorphism, meaning one particular change in one of those base pairs of the DNA. If they change, we have a different function. So why does it work for my brother and not for me? This is an exemplification of that chart behind. Let's take as an example intermediate metabolizer, which is one of the highest groups that are available or that exist for any population. In this case, on the left, you see that is an intermediate metabolizer, and a mom that is intermediate metabolizer. Themselves also got one copy of the gene, let's say for that star 4 from his father, and then star 1 from the mother. On the other side, you see the mother got star 3 from one parent and star 2 from the other one. The star alleles, the star coding, it's just a way to bucket those different versions of the genes of which ones work normal, which ones work a little less, which ones work a lot less, and which ones work a lot faster. So that's how we know where a specific variant of each genes belong. Then those two have 4 kids, and you can see the different color combinations, and you can see that among the 4 kids, you have the one on the left that this gene, this enzyme will work fine. So medications associated with that particular enzyme should have a normal response. Then the ones on the far right, that Medicaid works really fast. So medications associated with that particular enzyme, either they make too much of it, activate, or they get rid of it too fast. And those in the middle, that still may work, but may require some adjustments up and down, depending on up and down the dose, depending on what are the particular responses to that particular patient. So that way you can see why one medication or a given medication associated with this particular gene may or may not work for your siblings. So it all starts from where the gene's coming from, mom and dad, and you keep going back in generations above. And of course, the kids at some point will have kids and will keep going down. So this is why even in identical twins, when the genes are identical and they may have the same variants, there may be other factors that contribute to the expression of the genes, some other environmental factors called epigenetics, some other environmental factors that are not genetics that will have a saying, will be important for drug response. But in general, this is the way that actually happens. This is why, genetically speaking, one medication may work for you or for your brother, your sibling, and not for you. Another very common question that we get is, what's pharmacogenomics? Well, pharmacogenomics can be simply defined the study of a patient's DNA in relationship to how the patient will respond to a particular medication. And in reality, is the combination of 2 different fields. Pharmacology, which is the medications themselves, the absorption, distribution, metabolism, excretion, as well as the genes and their corresponding proteins associated with those particular medications. The genes associated with medications in 2 ways. One is called pharmacokinetics, which is simply defined as what we do to the medication, what we do to the medication, meaning we absorb it, we distribute it, we metabolize it, and we excrete it. Then what the medication is actually going to do to us, where does it act? For instance, psychotropics, antidepressants, act in particular receptors, proton pump inhibitors, your omeprazoles and such, they act in a particular cell of the stomach, inhibiting the secretion of hydrochloric acid. Your beta blockers, they act specifically in one part of the neurotransmission, electrotransmission of the heart conductivity to reduce the exchange of potassium and calcium to make sure that there's decreased function, so you reduce the rate. So that's where they work. So combine all these fields, it's pharmacogenomics, and it does require genomics and pharmacology knowledge to do it correctly.
Dr. Ruben, can I quickly ask you one question just to make sure people understand? 20-year-old, and so how would I know I'm a rapid metabolizer or normal metabolizer? If I know it, what can I do to protect my health?
Well, once you know your metabolizer status, let's say for a particular enzyme, then the provider can use that information first to select a medication that will work the best with that particular metabolizer status, or ideally select a medication that doesn't use that enzyme. Let's say that a patient is a poor metabolizer, use that enzyme, but another one that works well. If there are no choices, the provider will be able to use that information to gauge how much of the medication may be able to give you, following standard regulatory FDA guidelines, as well as monitoring the patient to see how the patient is responding and keeping an eye of those specific potential signs or symptoms that may come up from taking a medication. So any patient that knows their metabolizer status will get a benefit from many medications associated with that particular gene. And because the test is not, or any pharmacogenomics test is not just one, you will get a very good amount of information.
So Judah, are you rapid metabolizer or slow metabolizer?
I'm a rapid metabolizer, Dr. Agarwal.
You know it to do the testing, otherwise you will not know. Is that right, Dr. Rubin?
That's correct. There's no way to know. You could get a potential idea based on the medication and what it does to you, whether you are responding to it as is expected, as a person that everything associated with the medication is functioning perfectly. But if it deviates from that, clinically, somebody who's been doing this for a while may be able to say, hey, you may be a fast metabolizer or a poor or intermediate metabolizer, but not everybody has an eye for it. They need to be doing this for a while.
That brings us to this question: why anybody needs PGX testing?
Yes, so there are many different reasons, and it can go from the medication has a label that specifically says that pharmacogenomics is very important for this medication due to the potential adverse reactions associated with certain genes and their genotypes. It could be because there's a family history of certain not desirable reactions to a particular medications, because a patient has failed multiple treatments to address a condition. The patient may have multiple conditions, hence taking multiple medications. Usually something or a medication that is given at the standard recommended dose doesn't work for the patient or does too much for that particular patient. Patients that the dose needs to be adjusted too much or keeps going up and down and they never get the condition under control. The patient has experienced a very severe adverse reaction, or to improve the medication compliance with the medication is working but not as its best, and it's producing other symptoms that were not there before. So that's the reason mainly why patients stop taking medications and guilty as charged. I have stopped taking medications when it's just not doing what they're supposed to do. So you start not being compliant to what your provider said, and this may be one of the reasons why. So there are multiple reasons to do this.
So what you're saying, Dr. Rubin, I need to have a complication, adverse reaction before I get the PGX testing, is that right?
Well, it would be one example. Hopefully we don't get to that. And there is some, if not preemptive, at least preventive testing to make sure that is minimized, that risk is minimized. But yes, that is one of the most common reasons.
Judah is asking this question: why my doctor did not check my PGX before prescribing my medication?
All right. So that is actually very common. And the reason it's associated with the evolution of genetic testing. If we go back to when DNA was discovered, the helix itself in 1953, technology to analyze DNA started coming along in the 80s as we know it, when PCR, polymerase chain reaction, was discovered. Thiopurine methyltransferase, which was discovered by my mentor at Mayo Clinic, was discovered. The expression of those genes, little by little, were discovered. The association of particular genes, as well as the databases to create that body of knowledge behind what medications are associated with what particular genes, what are their functions, what are the pharmacological implications, what are the clinical applications, and ultimately, do they actually help the patient? Does it work knowing if you have a particular genotype, will it change the clinical pharmacology? Will it change the clinical outcome of the patient? That knowledge starts being accumulated since the Genome Project was completed around 2001 or 2001. So you're only talking about 20 years of existing of a field that it's growing fast. So it's common for providers to not to know that all this happened, that it's available, that we have the technology to analyze this correctly, that there are reliable evidence and solid information coming from regulatory agents, professional organizations, that while they're not equal and they should be used correctly and never contradicting each other, it's available now. So it's basically the result of the field evolving really fast and not allowing providers to digest it fast enough and to get involved in it enough. So for most of them, it's as if it didn't exist, or they know about it, but they don't know enough. And that will continue to happen. That's where we come in to educate providers and to show them the both utilities and limitations of this. This is not a magic answer. It's actually a tool to help the provider get insights into a patient drug response. So it's a back and forward education that needs to continue to allow the providers to use this in a very safe and comfortable way.
Dr. Rubin, do you think the patient should ask, become proactive and tell your doctor, listen, why don't you check my genes before you give me the medication?
Just like any other test, of course, the patients can ask, and then the provider can engage with an organization that can guide them through the process of doing this correctly. Every patient has the right to ask anything about their health, whether questioning a diagnosis, whether getting a second opinion, whether it's asking if those medications are right for them, based on what, are there any tests that can help us decide whether a medication is the right one for me? Yes, of course, the patient should ask this. However, the results of a test and the implementation of the test with a patient or on a patient should be managed by the healthcare provider.
This is a very good slide. How does the PGX help reduce ADR, adverse drug reactions?
What it does in a summarized way is analyzes several genes with what is called high level of evidence, meaning those gene drug pairs for which the body of knowledge behind those gene drug pairs is robust, is strong, and uses that information to gauge what is the potential drug response. It's not a black and white, it's the potential drug response for a particular patient based on that information, taking in consideration other non-genetic factors. It's not just genetics what composes drug response. It's how your organs work, your sex, your age, other medications you're taking. Some foods interact with medications and may potentially derail the way that the medication works. Other medications may, what I call sabotage. The technical name is actually xenoconversion. Sabotage how a medication works by disrupting how some of those genes, the proteins, work, and sometimes the expression of those genes. Based on that, the outcome is usually in the form of a color-coded type of bringing up to the attention to the providers what medications may work the best, which ones may require some caution to use, which ones ideally the patient should stay away from those medications or should not be used. There are a specific number of medications in which the actual FDA label says, if this medication, if the patient has this genotype, avoid this medication. So not a lot of them, but it does exist. So that way, the appearance of ADRs could be minimized and reduce the potential appearance of them. Of course, there might be other factors that are not considered that could potentially end up causing an ADR that are not considered. But this is one tool to try to account for several factors of drug response to minimize the potential appearance of an ADR.
So once you have the test done, do you need to have a repeat test done, or one time in lifetime is enough?
That's a great question that comes often enough. So when this test was created, there were 67 genes with 664 variants that meet the highest levels of evidence. A pharmacogenomics gene ideally should be done by targeted analysis, what it's technically called genotyping, meaning that you know the genes and you know the variants that you're looking for. There are other forms of analyzing a gene, which is called full gene sequencing. And there are several different ways to do it. You go after the regions that code for a protein that's called exome. That's what they call exome analysis or whole exome genome. Then analyzing the gene in its entirety, end to end. That's called your whole genome, right? A lot of these variants are in very unique regions of genes that, if not having the correct depth of analysis, whole genome won't detect, and a whole exome may not even get close to those. So if you were to use those technologies, in theory, you should have to do it only once in your lifetime. However, it's not there yet. It's far from it yet, actually. In a genotyping assay, targeted analysis like this one, well, if you get it done today, like when the tech was created, 67 genes, 664 variants, the sources and the knowledge behind those genes keep evolving. So the sources right now have 80 genes with the same level of evidence than the test and over 1,000 variants. That means that, yes, from time to time, you may have to test the gap that it's happening, because this is the one type of genetic testing that the knowledge, meaning what genes and what variants, is not static. It will continue to evolve. So in a genotyping assay, there will be a point in which you may have to run the test again, ideally just for the gap that it's being produced, not for all the genes. Everything that was tested before, you don't need to reanalyze it, but you may have to analyze the gap for those patients.
So let me clarify that. Once I've done the test and you told me I'm a slow metabolizer, can I be changed from slow to fast after 5 years?
That's not going to change. What it's going to change is there might be new genes associated with medications that we didn't know before, or they didn't have the robust body of knowledge as they do now, and they might be more variants for genes that we already know that are associated. Now, in that rare instance, a patient potentially could move the metabolizer status, because if you have X number of variants, let's say go back to the same 2D6 gene, and none of those variants were detected, and you analyze the normal variant and it's there, it should not change. But there are some assays, not this one, that does not analyze the normal variant. They assume that it's there, and if they add more variants and detect it, they will be changing the metabolizer status. In this case, for this particular test, the normal sequence is analyzed. So your metabolizer status was detected as it truly is. It will not change.
Let's see, what medications are impacted by PGX? Are they all medicine or certain medicine?
Oh, there's not all medicines that are in existence or available to be currently FDA approved for human consumption to treat particular conditions. It's around 300 medications right now with the highest levels of evidence. And again, remember what we mentioned before. Some medications, some genes are associated with what we do to the medication, how we absorb it. Some transporters are associated with that, like I said, CO1B1. How we distribute the medication, some chaperone molecules and other transporters, how we get the medication everywhere. How we metabolize the medication, and also transported of how we excrete the medication. When it comes to dynamic, what the medication does to us, receptors, for instance, psychotropics, ion channels, like beta blockers, enzyme, like statins, the target is an enzyme, and the immune system, like molecules that are immunoregulators. So many different medications in many different areas: cardiology, pain management, psychotropic medications, anesthesia, certain hormones, certain biologics, antibiotics, anti-seizure medications are within the scope of this assay. So it's roughly 22 therapeutic areas in a robust assay with a roughly 300 medications that meet the highest levels of evidence. So there's a good chance that within these medications, which are not only commonly prescribed, they also meet the level of evidence to be in a pharmacogenomics report. So it covers a wide spectrum of medications.
So I'm a smart shopper. So I go to Google and check those medicine out. And if I'm taking one of those medicine, I call my doctor. Listen, I want to get my PGX checked whether this medicine good for me or not.
Dr. Google, it's very generous about telling you what you need to do, because Dr. Google will tell you, yes, this medication is associated with this gene. However, not all gene drug pairs have the same body of knowledge behind backing up that information. The information that should go in any pharmacogenomics report should be only the highest, which means that it's robust enough to produce a form of clinically useful statement. It doesn't really need to tell you this is how much you need to take or this is how much little you need to take. No, it just needs to provide an idea of what is the potential drug response associated with that particular patient result. So Dr. Google will tell you, yes, this gene or this medication goes with this gene. Therefore, pharmacogenomics will help. What it won't tell you is, yes, this gene is associated with this medication, but it should not be in a pharmacogenomics report. Or test. What should happen is that question should be passed along to the provider, and the provider should contact an organization, hopefully a reputable laboratory testing like this one, that will engage the professionals that know about this and may say, yeah, this medication is in the report because it does meet the level of evidence of these medications, or no, these medications do not meet the level of evidence to be in the report. However, based on the condition, there are other medications that potentially could be impacted and useful for the patient if you were to use the test, and then it will be allow you to select something else. So that will always be the decision of the provider. Our responsibility is just to provide the information to educate the provider what's available to them, what tools are available to them.
So how do you apply PGX result in managing somebody's illness?
You can actually use it to select a medication, to select a particular dose. By doing that, you accelerate the benefit of therapeutic success by reducing a patient stop taking a medication. So by improving adherence and compliance of a particular medications. By doing that, it will reduce will have a less likelihood of the patient having an adverse reaction from the factors that are included in the test. Like I mentioned before, there might be some other factors that are not included and that's pertinent to every test that may not be accounted for that could potentially produce an ADR, but at least minimize the risk of one of them producing a potential drug response based on those results. And one of my favorites is to decrease the number of medications that a polypharmacy patient is taking, a patient taking multiple medications, that may not only be themselves, based on the patient's genetics, the best medications, but also interacting in a way with each other that is not the most beneficial for the patient. A good percentage of therapeutic failure or ADRs, adverse drug reactions, is caused by drug-to-drug interactions and phenoconversion, or as I call it, drug sabotaging.
So let's talk about you see a new patient, and how do you talk to a patient about PGX result? So do they keep that report to themselves? They keep that information to themselves? Should they share with every physician they go to? Should they tell their parents? They tell their children? How the information should be reserved and saved for and which can be utilized by the patient, not only for that particular time, for future too?
That's a very important question, because a provider approaching a patient about pharmacogenomics, first we need to acknowledge that you're talking about the most guarded and intimate information about any human being, which is your genetics. And your genetics should be yours, and you should know everything that is on it when a test is given to you. now or perform to you. We'll talk about that a little bit later. How the way to approach pharmacogenomics for a particular patient is first letting the patient know that there's no medication that comes free of potential ADRs. Any medication is associated, every medication is associated with a particular adverse drug reaction. Unfortunately, worldwide, but in particular in the United States, is the fourth cause of death, adverse drug reactions. We know this from studies and statistics coming from hospitals that report certain conditions, signs and symptoms that happen that end up leading to death of a particular patient, and then they trace back to a medication. That has a cost. The patient may not care about the cost for the healthcare of that, whatever is important for healthcare as a whole, but reducing that potential instance, that instant for as remote as might be for a particular patient for that of happening to them, and to try to maximize drug efficacy by using this information. Actually, those drug efficacy, but therapeutic success by using this information to select the medication. The provider should tell this information will be used, or we will use it to select the medication that based on this likely will work the best for you, will have the least chances of producing an adverse drug reaction, and that information works for this patient for the medications that he or she may be taking today, tomorrow, or later on, as the information remains available and remains useful for that patient. That information, yes, should always be passed along to other providers taking care of the patient, because the proper pharmacogenomic test should not be a unidimensional for a particular therapeutic area. It should be comprehensive for many therapeutic areas.
When you start talking to patient, the first thing they're going to tell you, listen, why everybody not doing it? You saving my life, you're saving 30%, you're saving money by doing this, you're reducing the admission, and you're saving lives by doing decreasing the adverse effect. So what are the barriers for PGX testing in general population? Why people not doing more frequently?
Well, the answer is actually quite simple for everybody. Everybody, patients, providers, payers, it's education. And education doesn't mean knowing about it, knowing that it exists and test everybody. No, it doesn't work like that. It's knowing when to use it, knowing what to test for, knowing what the test should include, knowing what the test should not include, what it should be produced in a report, how it should be reported. So there are many different factors that at some point makes this form of analysis confusing for those that are not embedded in it. And it's our responsibility to educate everybody to make sure that it's created correctly, that it's used correctly, that it's implemented correctly. And because all this is not just in one bucket of knowledge, you have discrepant levels of implementation. So those are the different barriers. It all comes down to education of every single person involved in this particular form of testing. The patient doesn't know about it, the provider doesn't know about it, the regulatory agencies want specific things, professional organizations have their own opinion, then payers are confused because you have conflicting information. So it does make sense that there's a little bit confusion, and those are the barriers that we need to overcome to make this test available, affordable, safe, effective when needed, and supporting the providers to do this. This is not a test that can be just ordered, then given to the provider and expecting them to do everything on their own. No, you need to have the proper team supporting the providers that will be available for the providers to call to help manage the patients in a safe and efficient manner.
Let me ask you, who is responsible for education? Like you're saying education to the patient, education, physician, education. The government should educate, or the industry should educate, or the society should educate for a test which save life, which improve care, and prolong life.
So that's actually really good that you mentioned that, because it all it all starts with the different schools producing healthcare providers. For instance, medical schools should include this and do it correctly to adapt that the new physicians should know how to know about it, know how to detect and identify proper testing, and know how to use this correctly. PharmD schools, the same. GC schools, the same. You move this to the patient, well, I think every healthcare provider has a responsibility to educate the patient about this. But what if the healthcare provider already doesn't know about this? Because as we mentioned, it has evolved so fast that not everybody is up to, well, they should reach to organizations, whether it's educational organizations, professional organizations, or reputable laboratories, to educate them about that. The laboratories themselves who do this correctly have an obligation to teach, to educate the providers of what is proper pharmacogenomic testing, proper reporting, proper implementation. So it's a multi-educational back and forward mesh, if you want to call it. It doesn't fall the responsibility within one institution, one person, one type of organization. Everybody should be educating on this as long as they have the proper body of knowledge behind it.
So you have one lab, two lab, third lab. Would they give the same result, or there may be changes?
So this is a great example of proper genetic testing. This is not just exclusive to pharmacogenomics. This actually happens to a lot of different tests. Here we have two laboratories. Remember when we talk about 2D6 that have those star alleles that are buckets of what the particular variant does to the function of that particular protein, whether it's an enzyme in this case, it's too fast, too slow, it's in the middle, intermediate, or works normal. Well, it's applied to other enzymes, like in this case, CYP2C19. Well, this test, laboratory number 1, tests for star alleles 2, 3, and 17. And laboratory number 2, if you see, tests for star allele 2, 3, 4, 5, 6, 7, and 17.
What is allele? What are you talking about? I don't understand. What is allele?
Allele is the version of a gene that you have. For instance, star 1 is one version associated with normal function. Star 2 is a different version. Star 3 is a different version. In the slide where we have the parents, we mentioned what the star allele is. It's the version of a gene that we get from each of our parents. And those are the items that are tested in pharmacogenomics targeted analysis. So here we have two labs that for the same gene test different parts of the gene, different variants previously known as mutations, the star alleles. The results come back from laboratory number 1 for that patient, and they report star 1, meaning that if they don't find any of the normal function of the variants like 2, 3, 17, they report star 1. They report normal function. Unlike laboratory number 2, that includes a more comprehensive analysis, and they detect two different variants, two different star alleles that are not included in laboratory number 1. And this is the reason why they may say, yeah, we do test for 2C19, but you need to check how many variants they test. And there's a little bit deeper information on that it's probably not for this presentation, but those variants, those star alleles, need to have also certain level of evidence. Now, this is one layer, but it's a multi-layer because inside each star allele, there are the actual variants that make up that bucket of star alleles, the actual changes in your DNA. For instance, this same laboratory number 1 for this gene that we talked about before, 2D6, for the star allele bucket test for star 4, test those particular variants. The ones that are in red are tested by laboratory number 1. However, for the same gene and the same star alleles buckets, laboratory number 2 only tests those particular molecular changes. The C, that means complementary DNA. We have 2 copies. Remember, it's a helix. 4181 at position 4181, a base pair that starts with a letter G changes to a 1 in a letter C. That's the only variant that is changed, that is tested by this lab. So this lab, because it didn't detect what the patient does have, reports a normal metabolizer. But lab number 1 has more SNPs or variants inside that star allele bucket, will be the one that is reporting accurately. So no, not all pharmacogenomic tests are created equal. This is why education is very important for the providers to ask deeper questions. What genes? For those genes that have star alleles, what star alleles you test, like this?
For ordinary cardiologist or ordinary physician and ordinary citizen, will have a hard time figuring out which lab is better than other lab is better. Don't they have a government control on the quality of the testing?
Not yet. That's what we're trying to establish, to make sure that the laboratories, there are professional guidelines about that. Yes, there are professional guidelines about what are the minimal requirements that should every pharmacogenomics test have to produce a clinically reliable test. However, to do that correctly, the test will have to be slightly larger than most tests, like this one, the one that we're talking about here. And that is the reason why not all tests are created equal. We are working on producing, meaning the community as well as regulatory agencies, to produce guidelines and consensus, both professionally and regulatory, to produce a reliable, safe test to make sure that the patients get the best and take advantage of this technology in a safely manner.
So which box the IGX fits in, laboratory 1 or laboratory 2?
In this case, laboratory 2. In this case, laboratory 1.
That is great. So the more they test, the better it is.
It's the more, but the correct more, not just any more, the correct more. Yes.
So if you do the PGX test, how often you can tell that will show a meaningful result that will impact the treatment or side effect?
Taking as an example, one gene, which is a transporter, one gene that in one particular population. So just to reduce variability and to narrow it down to as little as possible, to make it the least impactful, to show how much impact it still has. So there are approximately, in this particular population, this gene is associated as a CO1B1 with statins, and those are cholesterol-reducing medications. This gene is associated with your likelihood to have muscle pain, myopathy, all the way to rhabdomyolysis, or muscle breakdown. And that's very dangerous, not only for the muscle, but also for the kidneys. So approximately, there are about 39 million people taking this medication. From that population, about 76.1 fall into the Caucasian white population. And again, I did it on purpose to reduce the number, to minimize it. Based on that population, 22% have a decreased function, which means that that number of patients, the 6 million, will likely have myopathy all the way from muscle pain to rhabdomyolysis or muscle breakdown. Now think about it. If we add the other populations, we add African descent population, we add Hispanic population, we add Asian descent population, that number will multiply. So, and will multiply substantially, which means that with a test that includes several genes and several variants, you will never have, like literally, the statistical odds of that are infinite. You will never have one patient that the test will report all medications will work correctly or will have a normal response. Why? Because the association between a gene and a drug is unique. It's not one gene, that gene function or genotype, that molecular result equally associates to all the medications that are related to that gene. It doesn't work like that. You could have a patient that is an intermediate metabolizer for a given enzyme. And let's say 20 medications are associated with that particular enzyme. 10 could be, yeah, that medication will work. 5 would be used with caution. And then you have 2 medications that said, don't use that medication. And then the rest will say, well, you may have to increase the dose. So the association between a gene and a drug, it's 1-to-1. It's not one gene and all the medications equally associated.
Very interesting, Dr. Rubin. I'm a cardiologist, and I have a lot of patients who are on statin. And then when they start complaining of pain, muscle pain, I just stop the medication and give them something else. So I should be looking for these genes. They have problem, so I can treat them a little bit better.
There are other genes associated with statin's metabolism, which impact the actual function of the statin. So, yes, correct.
So what are you testing?
Right now, the test includes 67 genes and roughly 300 medications of the highest levels of evidence. All these genes come from the main sources that are both professionally and regulatory informations, FDA, that contain pharmacogenomics information, different ways, in different forms, but they all meet the highest levels of evidence. If you look at all those sources, you end up with this number. You end up with this number right now, which is included in this test. And again, it's a targeted analysis, which means that we're only looking for these genes. We're only looking for the variants, previously known mutations, associated with the medications of the highest levels of evidence for these genes. We don't know anything else about any patient's genomics or genetics. Nothing. No other genes. No other regions even of the same genes. Just what is useful for this particular purpose. And that's very important because we don't need to test more than what we need to use for the particular application. Test for what you need, not for what's available.
Maybe in 10 years, you'll know more, and then you test more genes.
That's why it said 80 to 1,000. Yeah, really no more.
So what conditions are treated with medication impacted by PGX?
This is a very important question, and the slide is busy because let's switch the way we want to answer the question. Rather than answering about what conditions, let's answer it by the different therapeutic areas, the different medications, and classify it by the drug class, and the different conditions that can be used for these medications. All these medications are associated and approved to treat specific conditions. So if you look at all these medications and look at the associated conditions that are approved, these medications are approved to treat, then you get what conditions are actually treated. They're a very large, if we actually were to look at the conditions, we will have a longer slide. So these are the medications associated with the genes that are tested in here. And you can see that they vary from anesthesiology, cardiovascular, gastrointestinal, immunology, infectious diseases. Just looking at infectious diseases, you can see the different type of infections that you can treat. Neurology, you can see the different type of neurological conditions. If we go to cardiology, well, you can see right there that it's good for arrhythmias, certain anticoagulants, antihypertensives, antilipids. So many different conditions within each therapeutic area. So rather than just listing conditions, look at the medications that are reported, and again, it's going, that will be used to treat those particular conditions. And remember, certain conditions don't come as exclusive conditions. They also have other secondary aggregated symptoms that also be treated. And some patients do have more than one condition, also known as comorbidities, that need to be addressed at the same time. So all these medications will be a deeper insight information about the potential drug response and the associated ADRs for each particular patient.
Dr. Rubin, looks like I need artificial intelligence to figure out what I need to do. Look like a lot of information here. Before I write the prescription, I need to know the patient medication which fit in this category. Then I need to know patient gene type to protect him from side effect and make sure he's getting the right drug.
Well, that is the goal. However, I would rather have the provider actually looking at the information than just a tool of AI. So I go, AI is beautiful and it will help us to narrow down things, but ultimately the provider's knowledge, intuition, as long as the patient interaction, which is the most important part of this, will give you the final answer of what you're looking to treat a particular patient with, rather than just outputting this is what you need to do. It's the patient relationship that should always be the center of any treatment, and knowing the patient really well. This is one extra tool to give you that information to do the best for the patient.
So once I decided I wanted to do PGS texting, walk me through the process, like how collect the sample, then what happened, and how the patient get the information.
So it's actually quite simple. Any laboratory, in particular this laboratory, will go through an onboarding process with the provider to show them what is the electronic and/or paperwork to order the test. Once the provider and the patient said, yeah, we're going to order this test for you, then the provider places the order, and two things could happen. Either the provider has the collection supplies in his or her office, where there is a vocal swab, or the patient is in an environment where they're going to draw a couple of blood samples for them. Well, also can be used for pharmacogenomics. And those specimens, whether there is a whole blood or vocal swab, they're sent to the laboratory. The laboratory then does all the paperwork correlation, whether it's for medical necessity, whether it's for payment coverage, whether it's to payment processing, if it is a self-paid patient. Then that sample gets processed, meaning extracted, analyzed. That data the results coming out of the instrument goes to the bioinformatics process of the laboratory, then pair with the knowledge databases about each of the genes and their associated medications. A report is composed, and then it's delivered to the provider in two ways: either directly connected to their electronic medical record via the laboratory information system, or to a particular secure HIPAA-compliant portal that the laboratory has, for the provider to do more than just retrieve the information, but also work with the portal and adding or removing information as the patient's medication change, and if needed, share those patient's results with another provider. As we said, these results will impact medications that are managed by other providers as well. So the goal here is that every provider that is managing the patient takes advantage of these results, not just the one that orders the test. So that is, in a nutshell, the process of ordering the test.
Very interesting. So once the patient get the result, does the patient keep the information to himself, or patient learn whether they're slow metabolizer or immediate or poor metabolizer or the rapid metabolizer? Do they keep the knowledge to themselves? Do they store that information to themselves? Can they use the knowledge again when the next drug is prescribed?
The patient will get a report from the provider after they review the results together. No patient should act on their medications on their own without the provider and the healthcare provider managing those medications should. So yes, after the provider acting on those results, on those clinical statements, those actionable statements, then the results can be shared with the patient, and the patient can physically take that report and give it to another healthcare provider if they choose to manage other medications. That report does remain with the patient, and that information will be useful for the patient at any given time. The provider will still have access to those results in the portal and can be shared at any time. The results will remain there, and we'll touch a little bit later in what happens to those results should the patient choose to allow it or not.
What kind of information are you getting when you order this PGX?
So for this, and I can only speak in relationship of this particular test. However, everything that I said and the opinions that I mentioned are of my own. However, this is the actual content of the test, and this is what we call the interpretative boxes. The reports are organized always in the alphabetical order, starting with therapeutic area. In this case, we jump all the way to P, psychiatry. Within psychiatry, drug class, so antidepressants alphabetically. Then the way the medication works, mechanism of action. In this case, selective serotonin recapture inhibitors. And within that box, you get the generic name of the medication, you get the commercial name of the medication, you get that yellow icon with a pill inside, meaning that that medication, it's been sabotaged by another medication that the patient is on, or it's being considered for treatment. You get the gene or genes associated with this particular medication, the genotype, the translation of the function of that gene into the protein and how that impacts the patient and the overall impact of that patient. You do get your color bar that tells you what is the action, in this case used with caution, the kidney and liver telling you whether that medication requires hepatic or renal consideration when using, and then the statements as they come from the different sources, not just one blunt statement looking at all of them together. No, not all sources are created equal, and that's why they have to be split correctly, because one has to take in consideration and follow what the label says, and as part of the practice of medicine, they can choose whether to use other professional guidelines. Like there are other professional guidelines, like the American Cardiovascular Association, American Diabetes Association, that they have their own guidelines of how to treat something. However, each medication has its own FDA recommendations, and providers should find a way to marry those two in the best interest of the patient. So this is, in a nutshell, the information that you get from this particular report.
Like don't use this drug because it's got a high risk for side effect, but it doesn't tell me which drug to use. Does it also give me some idea which my genes allow some other drug which I can handle this better?
Yes, it does. This actually particular report does have a summary section when you have all the medications that are reported grouped in the different categories, in the different color categories, where you get to use as a guide to select what are the, based on these results, the appropriate medication for the patient, and then using your relationship with the patient to know about other particular factors, whether that medication might be the best or not. This is the deeper breakdown of those statements for each particular medication. But the report does have a summary section where you can see all the medications organized by therapeutic area and their different actionabilities where the provider can select. Yes, you do get one like that.
Informed consent. So everybody give you informed, but my patient already gave me informed consent to take care of them. Do you need another consent to do the PGX?
Yes. Every genetic test requires its own informed consent. If we were to do pharmacogenomics today for the patient, this test requires its informed consent. If tomorrow we do a cardiovascular genetics for hereditary conditions, that test also requires its own. If later on the same patient requires another form of genetic testing, each test requires its own informed consent. The informed consent will let the patient know what's been done, how it's been done, why it's been done, and then what will happen to the patient's information. Will it remain in the laboratory for the providers use for the benefit of that patient only? Or does the patient allow that information to be used for potential studies, statistical studies, publications, and in some organizations, even the potential commercialization of the information it's mentioned in the informed consent. So the patients do have the right, and this is required by law. They have the right to allow the lab to do more than just reporting back to the provider or not. And this is a very important document. Any laboratory that does not have an informed consent is not compliant. The informed consent that this lab provides, ITX, is extremely comprehensive, explaining everything perfectly of how it should be done, both clinically, technically, and with the proper legal terminologies of how to do this correctly. We spend a lot of time on this form. So it is put correctly. It needs to be done. It needs to be done right. And also, of course, the professional ethics of each laboratory have a lot to do, because a form is a form. You need to, if it not act on it, then it's like it doesn't exist. And I can attest that, what it's being said and done here is exactly what it's happening.
Patient, and there's so much complexity in there. As a patient, I won't understand much about all these things, but it looks like I have to give consent to make sure my information stay with me and doesn't go in public. Is that right?
This form should be very well known. And this is the one form that needs to be very well known by any provider administering this and any other genetic test. So it is very important that the providers do read the form, get familiar with the form, and then explain to the patients, this is what we're going to do. This is how we're going to do it. This is why we're going to do it. What would you allow to be done with the data? Stays just for you, or allow it to use for other purposes? It just comes down to that. So that's what needs to be explained to the patient. Throughout the years that we've been doing this, we have received many different testimonials for patients that first, when they discovered that there was a test like this, they wanted their providers to order the test. And some of these patients had such a hard time finding out medications that work for them that it almost looks surreal that they were from one medication to another one over the years. And ultimately, after this test, the medication that was in some cases not used anymore because it's a previous generation or not the latest medication. That doesn't mean it's not going to work. It's just not a popular medication. End up being the one that works on the patient based on the both genetics and other non-genetic factors. So that's the case of Ethan at 62. Then we have a patient who was put on warfarin and the patient didn't respond too well, ended up with that almost deadly event, and then found out that it has a sensitivity to it, meaning it's gonna do too much for it. So the choice was the provider selected to use another medication that ended up producing the same outcome in a totally different mechanism, basically a blood thinner, that ended up working really well for the patient. So everything changed for this particular patient. Of course, when you're feeling sick, when you are at risk of having a potential known side effects, you get depressed. So this patient's mood changed. Now it's in a more upcoming, no problems for this particular patient, has no longitudinal known ADRs, and it's actually extremely happy that this test was performed for that patient. Now, as a side information, warfarin was one of the medications that started it all. And that medication went through the entire process of, it worked, no, it doesn't work for PGX. It's more than one gene associated, onto the current knowledge that we have that, yes, it wasn't working the way that it was done, the way that it's done right now. And especially because including all the proper genes in a particular test, it's done correctly. So here, it worked really well for this particular patient because of this test. Now, we have Sarah, 29, just 29 years old, and it keeps switching medications over and over and over. So it was finally after this test that the provider was able to say, hey, everything that we gave you is not what it's supposed to be working for you based on the information here. And that information was used for the provider to finally select something that was the most likely to work for her, and it did. It just works beautifully. Then you have Michelle at 54 taking several medications that were not only not working among themselves, but also not working well for the patient based on the patient's genetics. So they were able to select medications that they were safer for her, that actually do what they're supposed to do. And then we have Jenna at 36 who had, unfortunately, cancer treatment that the provider was very proactive to use this test to select medications to treat the patient comprehensively. As you know, cancer is not only to treat the cancer itself, but everything else that comes associated with having cancer, pain, psychotropic problems, depression, in this case, the cancer itself, the medications that are used for cancer sometimes themselves produce other symptoms. Things will appear depending on the age of the patient, the sex of the patient. So this provider was extremely proactive taking care of this. And all these testimonials, they just come to us. They suddenly just call, they call the laboratory, they reach one of the client services. Sometimes they get all the way up to me and we listen to them. And it feels so great to be able to help all these patients one at a time to change their lives by providing a test that gives not instructions, not prescriptions, not numbers when they don't come from regulatory agencies, not tell you what to do for the provider, but extra information for you to use with care and judgment applied to each particular patient by knowing the patient, by knowing what's going on with the patient. And that's how every test should be used. It's not just exclusive to pharmacogenomics. So we feel extremely happy when we get these testimonials for patients.
Let me ask you, we basically promote high quality care, but we also care about the cost, the low. We want to keep the cost affordable. So we haven't discussed the cost of this testing, and could you point it out, or if you don't want to talk about it, or Enrique, can you talk about the what is the cost of a test, like your cost versus a lab which do less testing, you do more testing? Is that different? And is it cost? If the study has shown that the spending money on this testing is a cost-effective way of doing it to reducing the adverse impact. So, in the world of value-based care, where we are with PGX.
The value of the test is not compared to the cost of the test. Let's say you take a medication that it's very commonly used and it should work for the majority of the patients, but in your case, puts you in the hospital for 3 months in the ICU, costing you tens or potentially hundreds of thousands of dollars. So that number in relationship with what you potentially could pay out of cash if you choose for the test, which, correct me if I'm wrong, Enrique, but the last number that I was given is $294, could have prevented all that. Now, there are 2 other ways that this test may be fully covered by a different payers. There is Medicare that has the specific guidelines to meet medical necessity, specific conditions that are always coded, called ICD-10 codes, associated with the specific medications, associated with the specific genes. Similarly, commercial insurance organizations have the same way of filtering the medical necessity, just covering different medications and different genes among the different commercial payers. So if covered, if the patient does meet medical necessity, whether it's by Medicare or commercial payer, the likelihood is that the patient will have a zero out-of-pocket. And if there was an out-of-pocket, the IGX does have a maximum out-of-pocket, and on top of that, payment facilities. So when it comes to the financials of the test, at least from this organization, there's no reason why anybody should stop or should not get the test for financial reasons. I've yet to see another one that facilitates this to the point. To at some point, the organization, coming a little bit below on this, because the interest of providing this test comes from a very personal happening to one of the founders, and we have him here, Enrique, and he has an invested interest in making sure that this is available for everybody. And to that tap on me to produce what we have, one of the best tests that is out there.
Our goal has been to work in understanding the regulatory guidelines of pharmacogenetics so that we can provide this test and make it available to everyone, because the same as Mayo Clinic, St. Jude Hospital, Harvard University, and very of the highest levels of hospital organizations. They have implemented pharmacogenetics themselves, and they are implementing it on most patients that visit them, because they understand the importance of drug response, which could save a lot of patients, lives, pocketbook, time, and it just optimizes the knowledge that they can have, which is our goal. As doctor said, education is a big piece. This is one way of educating, and which is why we put this webinar together, and I think that this has been a great opportunity to understand pharmacogenetics, understand why it needs to be ordered or maybe not needed for a particular type of patient that does not want to know, or it's up to that's why the consent is important, because they have to understand what they're going to do, and understand what that information could be used, not just for Dr. Agarwal, but for many, many doctors that they go see in the future, and in different countries, because the whole world is getting on board with pharmacogenetics. The doctor maybe had mentioned the UK study that is currently, I think one of the questions was in the chat room that related to if there's any studies right now being conducted.
So the first question that we got 3 or 4 different times was, where can I get testing? How can I find a provider that does testing, or where can I go to get it?
We have primary care doctors. We have urgent care centers, skilled nursing facilities, offices as great as Athens Heart Center, which is engaging heavily on pharmacogenetics. So it's through our website, innovativegx.com. You guys can read more information about the test. There's a 4-patient section in there. There's a 4-physician section, and there's general sections of education about particularly our test that we are performing at the laboratory based in Texas.
And Enrique, just a quick follow-up to that. Does the provider have to be established with PGX already?
Established as knowing pharmacogenomics? No. What will happen is any provider can reach out to Innovative GX and be onboarded to be able to order not only pharmacogenomics but any test that Innovative Genomics offers. So that's what will happen, and that's what should happen. So the provider has all the tools to order the test for any of their patients.
The next question we got is it protected information, or can the insurance company use this information against me?
100% protected information. This falls under HIPAA and to the FAIR Act, that no insurance information can use this. No insurance company can use this information to gauge whether you're eligible for test for coverage or not. So this is 100% protected information.
The next question is, what are the groups of patients or the diagnosis that will benefit most from PGX?
That's a great question, and a question that we could spend the whole hour talking about it. So like we show in the slide for the different therapeutic areas, it's more along the lines of what type of medications and their associated conditions. For instance, pain management, psychiatry, cardiovascular, neurology. If we were to break down the medications that we showed to their associated conditions, there will be a lot more conditions and the different types of the same condition that are treated with that. I mean, to mention just a few of them, in different areas, depression, anxiety, hyperlipidemias, arrhythmias, bacterial infections, some viral infections, hypercholesterolemia, seizures, So many different ones that are associated with different types of medications.
So is it covered by insurance?
Every insurance will have their patient eligibility. If the patient does meet the medical necessity as defined by the commercial payers or Medicare, yes, the test will be covered. The test will be covered.
Why would they not run the test for all alleles at the same time since they already have a sample?
That's a very good question, because we don't know, and this is the flat out honest question. It's just the way that it is. We know all the alleles present that are associated with potential drug response. We don't know what all of those alleles do. So if you just add those alleles to test them without knowing what they do, then you compromise the information that will be reported to you. We could say, yeah, we found this allele. We don't know how it impacts the gene, and much less we don't know how it impacts the potential drug response. That's from the do not do harm first type of thing. Then, well, you're just adding cost to the test for information that is not useful. So that cost will be passed on to the patients or the payers. So you want to minimize that. Could it technically be done? Yes, but there's no clinical benefit to it.
The final question that we got from chat that we'll ask is, have they started studies with a particular group yet, like those who take SSRIs?
That body of knowledge that I keep mentioning, supporting the evidence between the association of a gene or genes and a particular medication and a particular condition, are the studies and their publications that result in guidelines, professional guidelines, and in text included in FDA labels that support those associations. So those studies already exist, and they keep producing more and more and more. The study that Enrique mentioned that the laboratory is involved in the UK, it's one of the largest, and so far the largest, polypharmacy study in multiple therapeutic areas that not only includes genetics, but also includes the actual quantification of the medications in the patient's system by mass spectrometry and the clinical outcome. And that study will help to further support international guidelines to produce information to be able to robust what we already know and hopefully provide new insights about what we know for other genes that haven't met that level of evidence. So those studies already exist.
Thank you, Dr. Rubin. Those are all the questions that we're going to take tonight.
Let me take it from here. What we believe, our physician circle for patient, the responsibility of staying healthy is the responsibility of the patient. And I think patient should determine that they need to know everything about the disease process on what they can do, their lifestyle. They should, in our opinion, the patient should keep all their medical record one place. Now, in the modern world, there is an application from Health Well Safe where you can keep all your health information at one place, and every time you go to the physician, you tell them this is what I am, and tell me what I can do the best I can do. And IGX, Dr. Rubin and Enrique and Health Well Safe will work together. That once we have the PGX test, that PGX test will be used every time a new prescription is prescribed to the patient. So with that, I'll close here. Thank you, Dr. Rubin. Thank you, Enrique. Thank you, Chuda and Chesco and Richard and the whole team. You know, this on the backside takes a lot of effort to put things together. And Dr. Rubin did a lot of work, great work collecting information and simplify the information. So during this talk, what we wanted to do is we want our patient to realize it's your duty to understand PGX, ask a question. Once you have the answer, keep the answer, utilize those answers again and again to stay healthy as long as you want to be. Thank you all.
Thank you for joining our webinar. Be sure to follow us at Health Well Safe on all social media platforms so you can stay up to date with new healthcare technology. If you have any questions, please email us at info.healthwealthsafe.com. And remember, your health is your greatest wealth, and we want to help you keep it safe.